before we get going. Right. Tell us in the chat that you can hear us. Go ahead and put everything in the chat. You can see us and hear us, and we will get going here. All right. We are good. I'm just checking out a few settings here, and we'll get going in just a second. All righty. Okay, guys, we are good to go. I had to just play a little bit of music for my friend, Dr. Christian Subio, who likes to start off that way. For that, I figured if that song was good enough for Deadpool and Wolverine, it was good enough for us here.
It's very hip.
So I did the best I can at my age. That's how it goes. But welcome everybody. I'm gonna kick it off and get started here. We thank you. Just put it in the chat. Just want to make sure. Can you see both of us? Can you see us? I'm gonna put my slides right away so you can see the slides, because that's what we're gonna work off. So yes, they can hear us, they can see us, and they're all excited to be here. We really appreciate it. Feel free to ask questions at any time. Here we're on multiple platforms, so I'm going to try to keep an eye out here while Dr. Subio talks every so often here. Tell us who you are, where you're from, what kind of healthcare professional you are, and if obviously this interests you, because we've got hundreds of you on here, so we really appreciate you being on here on a Sunday night. We're going to make this a pretty concise program. Let me share my slides so we can really kick this off and get going. And so you should all be able now to see my slides, including Christian. Can you see them too?
I can, yes.
Okay, then we are good to go here. I just want to get the chats up where I like them so I can go ahead and see that. So really welcome. I'm just going to do some quick welcomes just because there's so many of you. It's going to be impossible to get everybody, but just so you all know who this attracted. We have Kate, who's an ARNP from Iowa, Tanya, who's a CMP from South Dakota, Anna from Cleveland, so she can't be too far away from me. Then Denise, who's from Turkey, who's a dermatologist. So I think we've got a pretty international crowd here. Stephanie, who's an RN from Salem, Oregon, and Michelle, an RN from Oklahoma, and they're coming too fast. But we've got physicians, JC, who's an OD from Wyoming, and we've got dentists, and they're coming too fast. And we've got someone from Tunisia. So welcome to all of you. Thank you so much for being on. We're going to try to cut to the chase here and give you the information you need. Christian, are you tired of talking about this topic? Because if we've been talking, you and I have both been talking about it, not just to each other, but we've given webinars on it. What do you think, Christian?
Look, I think we're fighting the good fight. I think we've done some good here in that I think we've moved the needle a little bit in the appropriate direction. That said, I think this will be helpful because this is kind of like a postscript to the whole ordeal, shall we call it? And what do we do with these complications? What have we learned? What can we do moving forward? So I think this is a necessary final postscript. Obviously, we don't want to be talking about this forever, beating a dead horse, but I do think this will be, a concise postscript to the whole matter.
Right. And again, I think as you and I talked, we talked about like this kind of like beyond PDGF. Like, what did we learn from this whole thing? And I'll be honest with you. I mean, I personally don't care. Christian, you're all going to make your own choices at the end of the day. You can accept it or not accept it. But how did we get here? It's not just PDGF. The same is true with exosomes. The same is true with PDRN. So all these things that, well, you'll decide. We're not going to go backwards. We're going to go forwards in this because, again, I can send you to the AAFE legal webinar that we did that goes through 90 minutes of all this, and it's and it's pretty comprehensive. But let's get beyond this. However, I do want to make this disclaimer: we are not a legal team by any means. So you need legal advice, go to an attorney. I could have some suggestions for you later on, but ultimately you are the ones responsible for your own treatment and for your own legal advice, because we are going to talk about complications and how to solve complications on something that we have no idea, they had no complications protocol for that. So I'll get do my own introduction. We'll do some quick introductions so everybody knows each other. But my name is Dr. Louis Maltzmacher, president of the American Academy of Facial Aesthetics, practicing injector and clinician with a very talented team of AAFE nurse injectors here in Cleveland, Ohio at our AAFE med spas. And we've got a few of them around the country as well. But we also, in the American Academy of Facial Aesthetics, do a lot of consulting with medical dental nursing licensing boards, with the FDA, collaborate with a lot of associations, and we do a lot of studies. We've got one major study going on right now on calcium hydroxylapatite for actually in the mouth applications. I mean, that's what we're into now, a 500 patient study. So we know this space pretty well. If you want to get a hold of me, that's how you get a hold of me. I am back. This is not just about me. I am backed by what I think by far is the best faculty in the world, about 80 clinicians who are just like all of you, and these are all of our faculty, but they all have, they're all real world injectors, and they're very successful, and they just love to teach. Believe me, they make more money in their offices than they do teaching, but they love to share and they like to teach, and a lot of them are our research and anatomists, but you're seeing physicians, nurses, nurse practitioners, PAs, dentists, and estheticians, dental hygienists who can inject. It's a really great crowd for this. It was from one of our faculty summits from a couple of years ago for that. And just to tell you what AAFE programs are coming up, then I'm going to turn it over. I'm going to introduce Christian and his programs too. We actually have a free training coming up in 2 nights, and this is going to be the top 3 lip filler and Botox techniques for Gen Z patients. This Tuesday night, it is free, just like this one is. And Gen Z patients, if you don't know, make up now over 35% of all injectable clients. And because I am a little bit older than Christian here, when I first started injecting 23 years ago, I mean, it was 40-year-olds were the young ones. Right now, they're coming in. It's crazy. And they all start with lip fillers and a little bit of Botox. So if you want that, there's a QR code for this, and AAFEwebinars.com, as always, where a lot of you found us on this one there too. And I want to introduce my good friend, Dr. Christian Subio, who a lot of you know, Dr. Subio. If you don't follow him, absolutely follow him on Instagram. Aside from the entertaining, he is a tell it like it is plastic surgeon, and the two of us don't always agree on anything, and we shouldn't agree on everything. I mean, that is pretty much what that is. And I just tried to get a couple of good shots of you here, Christian. So you're going without the glasses tonight, just so they recognize you. But I just wanted to give a shout out, and you can tell us a little bit more about this program here too that he has got coming up next month. But like part of it's sold out, Christian. So how do people participate? Go ahead. I'm going to turn it over to you.
Oh, cool. Yeah, thanks, Louis. Again, the kind words from you mean so much, because what you've built and the voice you've been in this industry, I can only imagine that all of your the culture comes from the top down in any given industry, so, or any given company. So just having spoken with you a lot over the past couple of months and before this, we've been friends for a couple of years now. Like, I've always enjoyed talking to you, because despite being someone who's created something that's so successful, you lead with integrity. So that matters to me, especially. That's the currency I'm interested in. Anyways, yeah, a quick plug for my thing. Next month we have Needle Art coming up. We have 400 people coming in person. It's sold out in person, but if you want to do virtual, you can attend virtually and get CMEs and then watch it for 3 months. And also, there's a couple tickets left to the Needle Business. That's 3 days of all just business topics, again, with playback for a couple months. If you're interested, you just go follow my website there, or the QR code, and check it out. It's really it's a special meeting, so it's my little baby. But beyond that, let's get to the business.
Okay, but first of all, thank you for your kind words. But look at that lineup. You got to get a bigger room than 400 people. No, no
Well,
kidding. That's really the best of the best. And we've had a lot of these people at AAFE events there too. I mean, this is really that is a top-notch
we
thing.
got to get you there next year
Oh, yeah, I appreciate that because
if you're in. So
somebody just said on Instagram, yeah, everybody but you is there for
no, I
that.
mean,
So
hey, we're already thinking about next year, so we'll be
oh,
talking,
that's
Lewis.
funny. There's always somebody got to give it to you there. All right, I appreciate it. I appreciate that, Dave. Thank you very much for that. Yeah, let's get to business here. But definitely support Dr. Subio's programs, and hopefully you'll find something in the AFE you'll like as well. Here's what we're going to cover again. Again, we're going to try to move this forward. If you want, all the background I can send you to the AFE legal webinar we had a couple of weeks ago there as well here. So we're going to cover these topics. I'm just going to jump in for this. But I have a question for you, Christian. Pretend you never heard of PDGF. And I'm going to start with PDGF here. Okay. You never heard of PDGF. You and I really, this is a question really for everybody in the audience there too. And I really want you to use the chat and put it in the chat. If I told you that there was a new product on the market, it is a topical product, okay? Forget that it's PDGF, just something brand new to the thing. Great topically for microneedling, for after laser, it takes the red out of the face, gets you expedited healing and that kind of stuff. And then I told you that, you know what? You should consider injecting this. But then I showed you this list of everybody who says you should not inject it and everybody who says you should inject it or you can inject it. I don't know. I'm going to ask the audience there too, and then I'm going to turn it over to you. If you saw this list, you didn't know anything about PDGF. Let's say it's, product X is the new X by Elon Musk because he likes to call everything X. So it's product X for aesthetics for that. And you saw this list of who says you should not inject it, including the company. Then you saw the other list of who says you can inject it. I mean, tell me in the comments, tell me in the chat. Would you think that you could inject it or not inject it? And Christian, I'm going to let you, as a new injector, not a new injector, experienced injector that saw this list. What would you think?
I mean, I think we discussed this. We've had a bunch of phone conversations, you and I, in the past several weeks. And I think the analogy I used was when it comes to this kind of thing where it's such an important topic, and if you're wrong on this topic, if you are wrong, it could mean your entire practice. It could mean a $500,000 or $1 million judgment, which is not covered by your malpractice insurance. It could wipe you out. They could come after your home, after your car, after all your assets. With something of this import, I'm going to need, and let's say there were 10 people weighing in on this, and it's about some new drink, and there's a question. Someone said, "Oh, this might be poison," and 9 of the experts said, "Oh, it's not poison. It's fine. We think it's fine." And one expert said, "No, this may be poison." Guess who I'm going to be most interested in listening to? It is that one expert.
Right.
And you could play with the ratios if you want. If you change it to 1 in 20 or even 1 in 100. If 1 in 100 said to me, "No, this may be poison. This could be the end of it for you," I'm going to weigh what they have to say, just coming from a place of being prudent. So when it comes to this, where the ratios are reversed, and all of these people, the FDA, the licensing boards, the very creator of the company, on the website, on the package, on the syringe, everyone is telling you do not do this. And you're able to find a couple of people who say, "No, I think we can get away with this." Guess who I'm going to be listening to here? For me, I just don't know how to explain. It's like trying to explain to someone that why 2 + 2 = 4 or why the color blue is blue. I just don't have the words to articulate this.
Right. I'm glad you brought up 2.2. That'll come up later for this. But it's just I guess that's what's mind-boggling really to both of us. And again, it's not to beat a dead horse. It's just when you see this, I mean, it's pretty straight. I mean, what really it all turned it for me. But I had a great conversation with Charlie He's the chief medical officer for Ariessence, PDGF, and he had worked on all the other PDGF products for this. And he kept saying for a closed soft tissue application of this product, we have no history, we have no studies, we have no idea what the dosage would be, we have no idea what complications would be, how to treat them. I mean, I can't. it's really something. And we'll get to maybe the bottom of it a little bit as to why this went ahead and happened here for this. But I do want to be, yeah, I really try to be fair because I talk to a lot of people. I talk to the attorneys that say that you can inject it. I talk to some of the injectors that say you can inject it. So I just want to go through a couple of their things, and certainly you did a lot of research. I don't have the graph that you made, but we'll be happy to send the graph to the you know that graph you made of all the PDGF products. But like they keep saying, PDGF is in 4 FDA approved products, which is true. But the fact is, what? There's no real approved PDGF product for soft tissue, closed soft tissue application. It doesn't exist. So there's no off-label that we talked about. There are many studies about the efficacy and safety of PDGF. And by the way, I've talked to you about this. I've talked to the company at length and know a lot of these people because many of them worked for previous companies in the aesthetic space for that. Everything that they say is true, and they keep saying don't inject it. We'll get to a little bit more of that later on. There are lots of studies, but none of them are for about tear troughs or anything else. And I spoke about, the chief medical officer already as it goes. And you brought this up. You really were one of the first to really bring this up. PDGF by itself doesn't exist, right?
Yeah, I mean, like
The FDA gives approval for what?
they give approval for the final product formulation, as in Regranex gel. That's approved, so you could use that however you want, off label, within reason. For Gem 21, that is a scaffold that is approved as a scaffold. There is the quote injectable onlay paste, which could be used off label because that has an approval. But you can't just subtract out one of the ingredients and say, oh, it's overall FDA approved. No, they and you did the hard work here, reaching out to the FDA, who corroborated, no, we only approve the final formulation. And I think this is important. It might seem like we're nitpicking here, but I think the analogy I used before was that if, let's say, a final product involves an acidic component and a basic component, and then when you combine them, it neutralizes for some gel or whatnot, you can't just take out one of the products lest they be acidic or basic,
Right.
or harmful in their own right. This is why it's so important to follow the letter of the law when it comes to FDA approval. There's a reason for all this madness.
Right. And funny enough, so when I was talking to one of these attorneys who's trying to convince me that this is all okay, they said, well, just take that Gem 21, which is a bone graft, which is a dental bone graft, and inject that. Where am I injecting a dental bone graft in soft tissue? Like I'm not putting it in the tear trough, so ultimately, and this is going to be our main point over and over. You are the healthcare professional, and you doesn't make a difference what your attorneys say or anything else for all this. And let's get to this.
If I may just interject
Yeah,
here,
go ahead.
as you're saying this, I'm almost embarrassed for our specialty. I truly am, that we have so many interesting topics that are worth discussing and debating and probing. And here we are talking about like this. To me, like, why are we even talking about this? It's
Right.
bonkers. And
It
you
should be.
understand this. I understand this. The company understand this. Like, it's disappointing. It really is.
Because I've never seen anything like this in 40 years of being in any kind of an aesthetic space and just being a clinician. I don't think I cannot. Can you think of another part of medicine? Can you imagine a cardiologist? Can you imagine someone saying, "Yeah, there's some kind of weird thing that I saw is good for your heart. Honey is supposed to be heart healthy. Let's go ahead and inject it right into the heart." Like it. It just doesn't make sense. This is so basic. It's just crazy. Well, we'll talk about where that comes from for that. But it is true that the FDA does not regulate medical practice. But I can tell you that medical nursing, dental licensing boards, and their practice acts, every single one of them relies on the FDA for approved products. So they don't directly regulate you because this is one of their arguments. The FDA doesn't regulate medical practice. So if you want to move medicine forward, then you should be injecting PDGF. By the way, Christian, I mean, I've looked at PDGF. We actually have it and we use it topically, and it's a nice product. Is this like the next Botox? Is this the kind of product that you would die on a hill for with your license?
No, I've said this before, and like I referenced this in one of the talks I gave. If you actually look, erase the hype, erase the smoke and mirrors when it comes to injectable PDGF. Like the problem is, if you actually look at standardized photos of the results, they're okay. You have to squint to see the results. It's very, very subtle. It certainly is not the game changer. Holy shit, look at this boat. This is the new Botox or new dermal filler. It is a very minor improvement, equivalent to many of the other tools that we have, fractionated lasers. I'm not going to get into it, but bottom line is it's so minor. It is not worth this gargantuan risk you are undertaking for this. The risk benefit ratio is simply not there.
Right, right. Especially when the company tells you not to do it in soft tissue applications. I mean, it's really nuts. So let's get to this topic here. And by the way, we have some great questions that are in there. Many of them are going to be answered, but we will take time to answer any questions that we may have missed. But now, what happens if a patient comes into your thing? And here is from the website of the company saying this is not approved by the FDA. And just to get the couple of questions that have come out from, I'll let you answer this. You know the answer to this. This is not approved by the FDA. Okay, so someone said, "What's the big deal? We're just using it off label." Go for it, Christian.
I would, I would recommend anyone who has this question recommend to these prior webinars we have done. We can make them available after the fact. Mine's on my Instagram page. You can send a link to yours. But look, the bottom line is they're, long story short, they are not FDA approved. PDGF, a liquid PDGF, is not FDA approved. Therefore, you cannot inject it off label. I know that's a little bit hard to wrap your head around. It was for me as well. But trust me, go to these other webinars we've created and look at them. They explain it really well. The bottom line is Ariessence pure PDGF, as I understand it, and again, I've said again, I'm happy to be corrected on this. They have sidestepped the FDA approval process by labeling the package not a drug, not intended to treat or modify the human body in any way. These products could literally be sold in Sephora. There is no FDA approval for any for this formulation whatsoever. Therefore, you are not injecting it off label. There is no label. It is
Right,
an unapproved
exactly.
biologic product.
You can't have an off label if you don't have an on label. And the
Correct.
company tells you it's not on label. But what happens? A patient comes to you, patient comes to your office and says, I was injected with PDGF. Okay, so two scenarios, and we'll get to complications. But the first scenario is you didn't inject them, and the patient is fine. Maybe they had a result, maybe they didn't, but now they're worried because they've heard about this. What would you tell them?
I would tell them if this literally happened to me tomorrow, someone shows up, look, I was injected with PDGF. I have no problems. How worried do I need to be? Essentially, I would tell them not very worried whatsoever. In all likelihood, if you were to have had a complication, it will be evident within the first few weeks to months, certainly. All right. That's not to say something couldn't happen down the line because we don't know what the long term implications are. But if you're asking me, all things considered, I would not be worried if I had had this injected into my face. As long as I didn't have any upfront early complications, in all likelihood, you're going to be fine. It is not worth losing a wink of sleep over. That said, if you have any kind of swelling or skin lesion or anything strange in that area, I would want to know, but that is highly unlikely. If you have made it over the initial period without a complication, I would expect you to be fine. So it's not worth the anxiety or loss of sleep, but stay vigilant. If anything changes, let me know. That's what I would
Right.
tell them.
And let's say you did inject them. I'll take this one because I saw some good comments on I think some of your posts on this because some people were saying I did inject it and here's what I'm telling patients. And the patient is fine, but they come in now they're a little bit worried for that kind of stuff. Listen, I stopped injecting this until I get more information. There seems to be I wouldn't say controversy, but there seems to be, I need more information to go ahead and do this. But you're fine. You got a nice result for that. We'll watch it. If anything ever happens, please go ahead and contact me. I would keep it very simple, and I would also go ahead and ask your attorney for advice and some language there as well. But now let's say you didn't inject them and they have a complication.
Could
You
I
did inject
interrupt
them.
very quickly?
Yeah, go ahead.
Just very quickly, I think people, it is important if you find yourself in that situation where you have injected someone and they're fine, they're fine, but they're coming in. I would say have your ducks in a row. Talk to your attorney, come up with a script, and be familiar with that script. It's not a disingenuous script. It's just
Right.
what your patients are looking for is confidence and confidence. All right. So you can't be like, well, I don't know, blah, blah, blah.
Right.
No, you have to understand, have the script memorized so you can adequately and efficiently articulate to your patients in a confident and honest tone that they're going to be fine. But the communication here is key. You can't be like hemming and hawing and uncertain. You need to have done your due diligence with this.
Right, because if you hem and haw, they will pick up on that, and they will be really worried. I mean,
Yep.
then they'll be really worried. But I think you said the key word. Be honest. Don't give them the whole run around. Well, there's other PDGF of things because that will only come to bear you
Correct.
for that. And if you didn't inject them, they have a complication. You did inject them, they have a complication. Now we got to deal with complication management. And I would say the same thing. Make sure you have a script. So let's get the complications on this. And then we've got a few other quick topics to talk about there too. So we want to really credit Dr. Leslie Gerstmann, who is, and there is her Instagram. Go ahead and follow her. She's always got a lot of great, interesting topics, but she has become almost like a magnet for some of these patients here. And you're going to see some nodules and bumps and redness, and especially some deeper things. These are not all cases of PDGF that have been injected by any means, but there have been a number. We have been, since our legal webinar, since you've been talking about it, we have gotten a number of emails. You've gotten a number of people that have gone on post and talk about it. I mean, it's kind of scary sometimes when you read some of these things, but these are actually really patients on this. So let's talk about if this comes in your office. Now, again, there is no complication protocol from the company because the company says don't inject it. So there is absolutely nothing. There is one study that if anybody reaches out to me, I'm happy to send it. I sent it to you, Christian, before, and that's where we're going to talk about a little bit of that. That talks about other growth factors in China that have been injected quite a bit and how they manage them. And I'll show you the flow chart in a second for all of this. But I mean, you've got to address these complications. And you see, the problem is, and again, I also, speaking to the scientists on PDGF, they don't know. You said, yeah, and you're right, that most of these complications are going to happen fairly quickly. Do we know how long they're going to last? Do we know that they're not going to start in 6 months? Because this is a growth factor, right? The company says this is the 300 times growth factor of what's normally found in human blood. That takes time to develop too, right? I mean, so, do we know what's coming necessarily, Christian?
No, case in point, that's part of the problem. Normally, when we are injecting a new treatment, it has been vetted
Right.
appropriately with the studies, the case series, the FDA for phase 1, 2, and 3. Normally, we have protocols. Number one, we understand what the complications are, so that we have in fact protocols to deal with them. But in this instance, we don't even understand. Not only don't we have the protocols, we do not even understand the nature of the problem. Are these vascular proliferative? Are they collagen proliferative? Is it a obstruction of lymphatic tissue? Are they nodules? Is it bony overgrowth because you put it on the periosteum and these have been studied in bone? Like, who knows? We don't know. So
Right.
now suddenly how to treat these things becomes quite the pickle.
Right. And I'm going to say it. You can agree or disagree or don't have to say anything. But anybody that's telling you a complication protocol is just there is no complication protocol. So we've all got to guess, right? So anybody teaching this or injecting this that tells you, well, this is how you manage complications, where's that coming from? Well, it's coming from our own brain. So we have some ideas too, because we're going to have to, you may end up seeing somebody that gets this. So let's take them through this, how we would do it. So the first thing I would do would want to refer it. And Christian says, yeah, me too. But I said, no, no, no. I'm referring it to you. You're the plastic
Oh,
surgeon.
oh no.
You can't
Oh
refer it
no.
to anybody.
Lewis, thank you so much for the referral, but I'm so busy this month. Um, Look, and again, not to make light of this situation, but herein lies the conundrum. Because,
Right.
I mean, I've talked to Lewis on the phone about this a few times now, but like, essentially, I'm at the point in my career where I have learned, and if there are any newer injectors tuning into this, this is very important. Like, this is one of the pearls you can take from this webinar, is that you don't always have to be the hero, because it's a very heady feeling when a competitor down the street, someone comes from them like, oh, they effed up my face. Dr. Subio, you're going to help me out. And I used to take oh, I'll help you out. I'll be the knight in shining armor. But with a couple gray hairs, you learn that sooner or later, these problems, is it worth taking on these cases? Because number one, certainly in a case like this, we're all flying by the seat of our pants. We're all kind of guessing. You are exposing yourself to medical legal liability. And if you could help the patient, in which case, phew, it all worked out. But it might not help, or worst case scenario, and this does happen, and this has happened to me, where I've tried to be the good guy and take on these cases, these really difficult cases, surgical or otherwise, and you get involved and you do your best, and it gets worse. You cause something else, and guess what? Now it is your problem. So I'm 47 years old now, and I'm at the stage of my career where it's like, I don't need to be the hero. I am looking to sleep easily at night. And these kind of cases, I didn't cause this stuff. I'm not injecting stuff that says do not inject. Like, do you want to assume the headache, the stress, the cortisol spikes, the medical legal liability, the unhappy patient who's now your patient? It opens up a whole can of worms. So God bless the patient that is taking these on. I don't know that as a seasoned surgeon and injector, that's not going to be me these days. It needs to be someone, a very special man or woman, who is a tertiary center for these kind of problems. Would you agree, Lewis?
Yeah, absolutely. I mean, everybody likes to be the hero, but then these cases come back to haunt you over and over. And quite frankly, we're not prepared for these kinds of cases. That being said, we're still going to go through, and because listen, you may be the only person out there, for that. I mean, first thing is you tell them to go back to where they got injected, right? But that person's probably not going to have much of an idea there as well. So listen, you can try to wait some of these out. You can refer it for that. I just want to though go through this, and then you prepared some slides too on complications. This is the article. If you want to take a snapshot of this and Google it and look it up, you'll be able to bring it up. If not, you can always email me. I'm happy to go ahead. And they tried a number of different things. I just want to show you their flow chart for this. And by the way, the 5FU, the 5-fluorouracil injection, that's the cream. That's not the injection. But that's for cancer therapy. I mean, that is, that's that. What they did is they took some betamethasone and they combined the 5FU with it, and they started injecting that hyaluronidase if HA was involved. 37% of these cases ended up in surgery, where they just had to go in and just debride it for that. But we do have RF microneedling. We do have lasers for that. So, and this is their flow chart from of the 65. They injected 28 of them. It was affected 23 times. 37 of them needed surgery, and there were still cases that were non-improved and unresolved. So, they're guessing too. They're all guessing too. But I wanted to take them through your slides right here.
Lewis, can we back up? I just want to show
sure.
a quick note on that last one. People, you see a flow chart like this, you're like, oh my God, like it's a happy ending. No, you have to look at this very carefully and understand.
Exactly right.
Resolved is 10% essentially of these cases. Resolved. They fixed the problem in 10%, 1 in 10. And if you look at 8 in 10, improved. 4 out of 5, 8 and 10 were improved. What does that mean? That means that they were not made whole. They still have something that's bothering them, be it lax skin, contour irregularities, discoloration. not improved 8%. So long story short, only 10% of these patients, including this surgical arm who had to have surgery for this, were ended up in a happy place. This is not a happy slide. All right. So don't think, oh my God, here's a protocol and 9 out of 10 ended up okay. We fixed everything. 8 out of 10 had some degree of improvement. 1 out of 10 had no improvement, and 1 out of 10 resolved.
Right.
So you
That
have to
is
like,
excellent, excellent point. Again, that's from this. I just want to back up even one more. That's from this article. Now, I just want to make it very clear. This is about exogenous growth factors. PDGF it specifically was not one of them, but it's the same. It's the same concept. They're all growth factors that were injected. Some of them were injected full face. I mean, some of the complications slides were pretty scary. And they actually say one of the first lines of their article, if you read it, saying this is illegal to do in the United States. These are not FDA. None of these are FDA approved for that. But it's a scientific journal. They're not. They're
that's a
not
minor
attorneys
point.
either.
This whole
What?
legal, it's a
Yeah,
minor
right.
point, the
Well,
whole
yeah, we'll leave that
legality of the
aside.
thing. Yeah.
But you're right about this. I mean, I didn't even realize the severity of this. It's a 1 out of 10, and the others are improved. And again, they didn't do follow up, so they don't know if they never improved. They may have improved, I mean, certainly, but there are those that didn't improve there as well. All right, take us through these slides here, Christian.
So basically, I mean, again, this is my take on things. This is not based on research because again, there is no research based on this. But as far as all the anecdote that I've heard, I've seen your cases, I've seen Dr. Gerstmann cases, people have sent me cases. They tend to come down into different degrees of concerningness, if that's a word. Nodules. Look, nodules some of these nodules don't resolve. And if someone has nodules, I put it in green because that's a good thing for me. We have a targeted area that we could
Right.
either try intralesional injection of steroid and 5-FU. Worst case scenario, we have something to go after surgically. That to me is a good story. You have a nodule, you have a target. Discoloration I put in yellow because that's a little bit more concerning to me. Like, it's a bit more nebulous of a target. Discoloration, is it in the dermis, is it in the subcutaneous, is it deep vascular proliferation? We don't quite know, so it becomes harder of a target to treat. And then the worst complications, if you ask me, and again, this is anecdotal, my opinion, is the edema cases where people are showing edema in the area. It's puffy, it's waterlogged, and it's firm. It has changed the nature of the tissue so that when they smile, they get this malar animation deformity. And you could see this with fillers as well. You know what I'm talking about.
Right,
They
sure.
smile and those little balls form right here because the tissue is not supple and pliant. So these are the more concerning ones because not only don't we understand what's going on, but we do not have a discrete nodular target to go after. And then finally, even more concerning perhaps are the complications that you mentioned that we do not yet know. So it's not just like, oh, there's complications. There are different flavors of complications, which may be different degrees of difficulty to treat these things. So that's all I
You
wanted to point out with this.
you are ever the artist. I knew there was a reason for the colors. I just didn't know what the reasons were. So now take us through this one here.
So to that point, like often, most of the complications, not all of them, involve some degree of discoloration. And again, problem number one, I'll say this again, we don't know the nature of these things. Is it a vascular proliferation? Is it a lymphatic blockage? Is it a collagenous proliferation? We don't know. But when people talk specifically about this discoloration, the blue or purple or red discolorations, people are very quick to be like, oh, okay, we'll just do lasers. We'll do vascular lasers, that catch-all term. But the way people are being trained on this is to inject it deeply on the periosteum or is supraperiosteal. And if you look at the depth of where the periosteum is in the tear trough, it is between 5 and 8 millimeters, almost a centimeter. Okay. If you look at the most of the modalities we have, lasers to treat these, KTP laser goes between a half and 1 millimeter, certainly not very deep. Pulse dye lasers between 1 and 1.5 millimeters. And DYAG may go deeper between 3 and 5 millimeters. And then IPL and BBL, certain wavelengths, the ones that hit deeper where this stuff has been injected, the point being, the deeper it goes, the less specific these wavelengths are to hemoglobin. So when you're getting closer to the actual planes in which these things have been injected, the less specific, the less efficacious these wavelengths are. So it's not just, oh, we'll try some vascular laser. You have to understand that most of these things have been injected deeply. So your BBL laser, most of those wavelengths are going to hit around 1 millimeter, going nowhere near your IPL, or it's going nowhere near this layer. So we talk about radio frequency microneedling. A lot of people bandy that about as a potential intervention. And I think that would be one of my go-tos if I were to address these things, because I think I have one more between 1 and 8 millimeters if you're using Morpheus 8, because it can go certainly down to periosteum. And the idea being, and again, people, please don't take this as gospel. There's no science behind this. This is an unscientific, completely anecdotal explanation here. But like, okay, they're going down, the tips of the needles are going to pulse, like it could ablate this vascular proliferation. It might sear some of these lymphatic channels. It might cause some kind of reorganization of the collagen. Look, I don't know how efficacious. There's no science here, but this treatment does at least affect those very deeper layers, 6, 7, 8 millimeters, getting closer to the layers into which it's been injected. So that's not to say this is the end all be all. Every case is going to be very difficult to approach. Every case needs to be tailored to its specific anatomic findings.
Right. And two things on this. First of all, this same thing applies to exosomes. The same thing applies to PDRN. We've seen cases of exosome nodules, and we've seen cases of PDRN nodules, because we don't know what these things are. Nobody knows. And they all say, don't inject them for that. So I guess the main point is stop injecting it. And RF microneedling, the FDA just put out a bulletin about RF microneedling for that, which should not affect most of you if you've been trained and are using it responsibly, because that's pretty much what the FDA was saying for all that. Someone just asked though, and hi Jerry, it's Jerry knows your stuff. When RF microneedling cause increased inflammation and actually increased nodules, similar to delayed hypersensitivity reactions? What do you think?
I mean, I would say that, look, I mean, we don't understand the nature of these things. Like inflammation, the RF microneedling would be a temporary, I mean, in virgin skin, RF microneedling would go down and cause these, it's essentially heat, pulsed heat at the tips of these needles. It's going to cause inflammation, yes. I don't think it's going to cause new nodules, because the nature of these nodules is not inflammatory. The nature of these nodules is proliferative. So, but here again is where I don't want to get too far ahead of myself. This is where I'm getting very unscientific and making these. This is all conjecture. I mean, Jerry may be right. I may be right. Who knows who's right? That's the very reason why we have science to study these things before we actually go and do them. So
right, and this goes again. It drove me crazy when they kept giving me the argument. Well, we've got to move medicine forward. You don't move medicine forward by injecting unknown substances that you don't know how to treat their complications. You move it way backwards. I mean, just way backwards. We'll get to liability and those kinds of things in just a minute for that. I will just say one thing. I mean, you said you will try your hardest to refer these. Anything. If you do try to, let's say it's your patient, you feel bad and you want to, you injected it or you didn't inject it and you just want to try to help them out, you better have a real informed consent that talks about complications, that talks about we have no idea because there's no science on this, because this was a not FDA approved product. So don't even think about trying to treat a complication with exosomes, PDRN, PDGF without really talking to your attorney and having an informed consent.
And if I could add something to that, Lewis, I would say, look, because this is unstudied, there are no guidelines. We are fumbling our way forward in the dark. You want all the information you could potentially gain, not only for your medical legal documentation, but to try to do this scientifically. I would want ultrasound. I would refer to, especially if it's a nodule, I'd want someone who has ultrasound guidance. I would get an MRI. One could even consider getting a biopsy to delineate what is going on. You want as much information at your fingertips. before you proceed. And even then, trying things sequentially. Start with expectant waiting. Maybe we give this another 3 months to see if it doesn't get better on its own, and then try the lesser things, i.e., the IPL, BBLs, or some kind of lasers, or before you start injecting steroids or steroids and 5FU combinations, which could have everything can cause its own complications. So
Absolutely.
you just give it some time, get as much information as you can, and then start sequentially with the lowest risk things, and then proceed upwards. Have a very low threshold to have a surgeon involved, certainly if it's some kind of target like a nodule.
Right. And absolutely tell them obviously, but you know what? For those that may not deal with complications too much, if you're doing watchful waiting, if it gets worse at any time, call me right away, and let's take a look. Send a picture. I mean, today it's things are so much easier with all of that. But these are going to be tough cases. I mean that's for sure. Holly says, I know derms like biopsies. Maybe refer complication patients to them. Refer them to whoever you don't like, because these are going to be tough. These are going to be tough cases. I'm just tongue in cheek. All right, let's move on. Again, I'll come back and answer questions, but I think the next few slides are going to answer a lot of the questions. We're talking about how did this happen, Christian? And you're the social media expert. How in the world did this happen? Because one thing that really drives me crazy, there's not a single patient out there that ever knew anything about PDGF. There were no direct to consumer advertisements, right? Nothing. And all of a sudden, I mean, there were a lot of injectors, and we in the AAFE, we had, just not from our AAFE members, but from a lot of people saying, hey, should I inject PDGF? My patients are asking about it. So how would they even know about PDGF? You're the expert here.
Look, this is a problem of our own making. As much as social media has made my practice and has made my brand, this is the exact problem with social media, in that it has made us way too lax. Ladies and gentlemen, we still have to realize we are all scientists. Whether you're a doctor, a nurse, a PA, a dentist, an esthetician, we all have to be grounded in science. And social media has made it so easy and fluffy to just bypass that science. Like, oh my God, hey everyone, look at this new buzzy thing. I'm smearing salmon sperm all over my face, so now I'm just going to inject it. Oh my God, I'm obsessed with it. It's unserious. All right. So while science is dry and boring, and I don't like science, I barely ever published any papers whatsoever. I'm not a fan of, it's not my thing, but I respect it. All right. Science is the guardrails that keeps us honest. And in this day and age, and this is why, Lewis, I'm a fan of what you're doing, because you approach your classes when you're training doctors, nurses, dentists, whoever, you're training them all, steeping them in science and the scientific method. We have to remember that's all it boils down to, a disrespect for the importance of science. And that's it.
Right. And again, in the case of PDGF and somewhat exosomes there as well, PDRN, I mean, the Samosferin thing is just completely, some of you are saying that bonkers, like it's just bonkers. But there is science in some exosomes, not much. There's a lot of, again, I'm going to defend PDGF, and there is a lot of science in PDGF, but not to this application where nobody has any idea what is going on for this. I mean, this was all social media driven. And there was a conference this weekend. A few of you emailed me or DM'd me that there was actually a conference, an aesthetic conference this weekend, that someone was doing a PDGF injection demonstration. They told everybody in the room, phones off, you cannot post this or this, just because of the controversy. We don't want to do this. If you've got to tell an audience, I don't know how many people were there, let's say there were 150 people there, to shut off your phones, we don't want anybody videotaping this because of the controversy. Would you agree, maybe there's something wrong?
I've gotten a lot of shit, people saying I'm arrogant or academically arrogant, or somehow I'm the shit. Ladies and gentlemen, if you're at a scientific conference and they're telling you to turn off your phones lest someone show how irresponsible you're being, that is stupidity. All right. And I'm sorry, maybe it makes me a prick, whatever. Call me a prick. That is stupidity.
You behaved yourself so far. I forgot to tell you, there's no swearing on the AAFE
I'm
webinar.
sorry. I'm
No,
sorry.
it's okay. It's okay. You do you. It's all right. You do you. But the whole thing is social media driven. You can explain that to patients that there's no science for this application on this. If I had $1, I swear we would all be really wealthy. I would share it with you, Christian. For every time an injector, a clinician says, "But my rep told me it was okay to do this. My rep told me that this was within my scope of practice. My rep told me that this device is going to solve the world, right?" And same thing with KOLs. Okay, you've got how do you approach this? What do you tell people that say my rep told me this is okay? Oh, I saw KOL to go ahead and do this. You're first of all, the rep is there for one reason. It's sales, period. Okay, and you are the mark, to put it bluntly. And a lot of reps are helpful and they're selling good stuff, but they're there for one reason. It's the sales. But how do you deal with this? I mean, we deal with this all the time. It's like, why? I just gave you a whole course, right, on neurotoxins, right, with all the science, with all the greatest techniques, the precision that you need, everything else. Oh, but my rep told me that I should inject. I swear to you, this happened. I swear to you. We had a patient come in. She was the injector was being trained by the company rep. I won't say which company. It was a neurotoxin, and the rep told the new injector, to inject 40 units into her forehead. Okay, 40 there. I don't know of any forehead that would ever need 40 units of neurotoxin. Okay, with similar dosaging to Botox and Xeomins. I won't say which one of the 4 possibilities or 5 possibilities now that it could be for that. 40, and they said the rep told me that, and the patient came in, said, the rep, I got 40 units. I said, who told you that? No, the rep told the injector 40 units. How do you deal with that?
I mean, I think it all comes down to having your head screwed on straight and approaching everything with a critical mind, critical thinking. And look, I love my reps. All right. The reps look, they're good people for the most part. All right. They're trying to provide for their families. They're just selling the product. Their reps are going to rep. All right. They're going to work for the companies. And that's all. You have to realize that they are employees of the companies, oftentimes with no scientific background whatsoever. Their job is to give you the bullet points of the company, be it a laser or a toxin or a growth factor or whatever. Their job is to sell for the company, and that's so be it. All right. Your job is to advocate for your patients by thinking critically, by knowing the science, and by starting from a place of show me the evidence. All right. It is on you. It's not on the rep. The rep is not beholden to your patients. You are beholden to your patients. It is your job to protect your patients from big pharma. That's simple. Start from a place of critical thinking, show me the evidence, and have a common sense when it comes to realizing that these people are doing a job.
And this exact same thing goes to KOLs. And they're great KOLs and they're great educators out there. And again, whether they're paid or whether they're not paid, for all of that is really beside the point. Everyone's got to provide for their families too. And there are better KOLs and there are, KOLs that you see them with one company today and then the next week they're with another company because the first one stopped paying them. That's all fine. It really is up to you. You've got to be, and if anything we learned from any of this, and again, we're not talking about anything specifically here. It can be PDRN, exosomes, PDGF. It could be any device. It could be any of these things. Any of these things can happen. I will say that Ariessence did a really good job, and I can say for all the reps that I ever spoke to, all said not to inject because it says it everywhere there for them. I give them a lot of credit for all of that. I won't go into anything more than that for right now for that. But I'm going to go to attorneys and malpractice, and feel free. I'm going to kind of take these real quickly, and this will answer a lot of the questions that are in the chats. But feel free to jump in there too. You said 2 + 2 before. There's a famous attorney joke. I don't know if you know the attorney joke. Somebody asked, a client was asking just their kid, their 5-year-old, fifth grade kid, how much is 2 + 2? They said 4. And then they talked to the kid who's in college. And they said, how much is 2 + 2? And they said 4. And then they called their attorney and they said, how much is 2 + 2? And the attorney said, how much do you want it to be? I mean, that's what attorneys are. They're there to advocate for whatever you want them to advocate for. And and again, I spoke to 2 attorneys specifically, but I know there are more who said that, injecting exosomes, PDRN, PDGF, especially PDGF, is defensible. Yes, anything is defensible. Why? I've got to advocate for AAFE members and injectors all over the world for that, and the Christian as well. Anything's indefensible. Do you want to pay to have to defend it? I mean, if you have ever been involved in a board investigation or any kind of lawsuit, doesn't have to be related to clinical, right? These things take time. They take aggravation. They take your soul, and they take a lot of money. Okay. And they take a lot, and you wish you never would have gotten into it. Why would you ever inject something that's defensible? Of course it's defensible. You're an attorney. And by the way, the 2 attorneys that I mentioned, including the 3 attorneys that I had on for my legal webinar, I would refer clients to all of them, okay? Even the ones that say it's defensible, because these guys will fight to the death. But just remember, you're the one that's paying them to fight to the death. The attorneys always win, okay? Whether you win or not is besides the point. The attorneys always win. The attorney also told me, again, if you ever hear this come up, that the medical board, if let's say somebody injected PDGF and somebody reports them, a patient has a complaint, they report them. Every medical, nursing, dental board has got to investigate every single complaint that comes in. That's the law for that. They say the medical board, if you injected a non-approved FDA product, yeah, they'll look at a lot of factors. No, they won't. I work with a lot of medical boards. I get calls from medical boards while they're in the meeting. Someone who's an AAFE member, we have a lot of AAFE members that sit on medical, dental, and nursing boards because we've been around for so long, and we've got nearly 15,000 members across the country. They'll call me from the meeting, like they'll step out and they say, "Do you know anything about this thing? Can you just give me some quick information?" They're not. I don't want to say they're. How do I say this nicely? They're not sophisticated that they're not going to know everything about this. They know one thing. You injected a non-FDA approved product and they will be upset. Okay? That's all they have to know. There are no other factors that are going to save you for that. You can be the greatest clinician in the world, and be careful. This is not to you, Christian, but one of the medical boards sent me something from a double-boarded plastic surgeon. I don't know what else he was boarded in, and he came in like the expert. They could care less how many letters you have after your name. If you're not doing what's in the Medical Practice Act and they find it, or you inject a non-FDA approved product, they're going to get you. I mean, there's nothing that's really going to save you. That being said, I think the bottom line is you should always have a good attorney. Will your licensing board agree with your legal advice? Not necessarily. They may or they may not buy it for that. But just remember, you'll be paying the attorney bill. Everybody starts off the same way whenever they get into an investigation or whatever. I am right. I'm going to fight this to the death. $10,000 in, they start to think, you know what? Maybe not to the death, but let me go a little further. 20, 50, $100,000 in, they're like, man, I wish I would have settled this from the beginning. You're into it. It literally takes your soul. I mean, I can just tell you from dealing with a lot of people, because we get the calls and we're sometimes the intermediary. We work with medical boards and we work with a lot of people. We all do dumb things. I'm not blaming anybody. I mean, this is what happens, but we keep saying it over and over again. You're the clinician. You're the final thing. Doesn't matter the advice that you get. You've got to have some common sense here. And I think, that's somehow this, we've never seen anything. Have you ever seen anything like the PDRN exosomes and especially PDGF? Have you ever seen anything like it?
No, and I think that's why so many people are confused. Man, why are you making such a big deal about that? Because it's so mind-boggling. If this is the precedent we are setting for the next dozen things that are going to come on the market next year, my God, our industry is already a joke. I just don't want to be further of a joke. I want to steer us back towards some semblance of being a respectable medical specialty. That's why it's so important. No, I've never seen anything like this.
Right.
It's
And patient
ludicrous.
safety. And that's why we would do what we do. But you're in charge. Let me just hit malpractice insurance because there were a lot of questions about malpractice insurance. At this point in time, 98% of liability insurances do not cover Arieson's PDGF injections or exosomes injections or PDRN injections. We did a lot of work over the last few weeks, and I can tell you that there are approximately three malpractice insurances that still do cover PDGF. One will probably be out of business in about 6 months. It's like a C-rated firm, so I wouldn't this. And by the way, some of this is coming from the insurance agent who was on another webinar with someone who injects PDGF and have this insurance agent on. And the guy he has no agenda. He doesn't care one way or another. Like he's an insurance agent for this. So this was after a long conversation with him, and he's telling me all of this. But they all have a non-FDA approved exclusion. Don't be surprised if they promise you they'll cover PDGF and then they come back later and say, well, no, you never told it was not FDA approved. So there are a lot of outs for them to go ahead and do this. I will just beg you that whenever you add a new service to your practice, no matter what it is, it can be a new device or a new anything, contact your malpractice insurance agent and have the agent check with the underwriter, who is the final word on all of this. Don't take your agent's, your agent may or may not know. It may be very topical. I will tell you this, and this is, I know of about three to five insurance agents who are really specific to the med spa and aesthetic industry. Everyone else is just relying on whatever else they hear. They don't really know it. One of them is this fellow Logan Floyd we use in the AAFE. We refer all of our AAFE people to him for that. So if you're ever looking for malpractice insurance, I don't make a penny if you get it from him or not. But he is probably one of the most knowledgeable in the med spa space for all of that. You never want to have to sue your insurance because now you're really flying. All the money is going out of your practice. I mean, literally, that's how practices go ahead and go bankrupt. What do you have to say about malpractice insurance?
You hit it. I don't have anything to add. I have nothing more to add there. You hit it.
All right, last couple of slides, but could you stick around for 2 more minutes and take some
Sure, yeah.
some questions? Let me go this. The bottom line, just go straight to the bottom line. Check your liability insurance. Always have a good attorney. Never inject anything unless you know how to handle complications. And that's whether it's FDA approved or not, right? Don't inject anything. I'm not even going to take a poll because this would really be embarrassing if I took a poll of how many of you that are on right now, the hundreds of you on the different platforms that are on right now, how many of you have hyaluronidase in your practice? Because there are a lot of people who don't even have hyaluronidase in their practice. Would you agree, Christian? If you inject hyaluronic acid fillers, you must have hyaluronidase in your practice?
Yes.
Like this is another thing that just is mind-blowing, right?
Mind-blowing.
You've got to have that.
Not just have a vial or two. You need to have 10 vials and a backup to send you more.
Right. Like whatever it is, have friends. I mean, I always tell people, you know what? If you're friends with a bunch of injectors in town, then everybody have some, and then know that you can rely on other. Also check the expiration dates because 6 months they're dead. So that's then you come to another conundrum, right? You have an emergency, and now you've got to now you go to your vial and it's expired. Now you really have a problem because you've got to use it, but if there's a bad outcome, all right, well, we'll leave it. Have good hyaluronidase, but never inject anything in this unless you know the complications for that. And I'm going to put contact information up here again with this. I'm going to leave this up so you guys can take a picture of it if you want to get hold of us for that. And again, I'm happy to send whatever I mentioned through this webinar. Let me see if I can take some questions. I'm not going to read all the comments because we would be here all night. You're welcome, you're welcome, you're welcome. Community has to prevail in times of the wild, wild west, that's for sure. Let's see. What about using PDGF topically with microneedling? Are malpractice insurance companies not opting to cover this as well? I've only heard of one case where that's the case. But I think if you're using it appropriately and topically, everyone else is doing it. There is, though, an Arieson's exclusion going around the malpractice insurance companies as a result of everything that's been going on the last few weeks and what's all come to light. But that is only for injection. So, they know to look out for that, for all of that. Monica, thank you very much for your kind comments. She said it was very refreshing, and we know that you are very involved in this space. So we appreciate that. Let's take a look.
I would
Let me
add with
just
the
see.
microneedling, like, I mean, look, everything we do is a risk. And when people say, oh, you have to take some risks to advance the field, or you have to take some risks, or else you will get left behind in the dust, this is true to an extent. You have to weigh the risk versus benefit. And when it comes
Right.
to microneedling in PDGF or drizzling it on after a laser, I have no problem. I've done that once. Um, Look, that to me is an example of something where the risk is so low and there is some real benefit there that, look, yeah, the science is not strong there. They have one paper in the Journal of Cosmetic Dermatology. The paper has all of 14 patients, and one of the co-authors is the very editor of that journal, Dr. Whoever, but who was also paid by the company for. So it's, look, but the bottom line is it is the risks associated there are so low as to be like, okay, we can't be paralyzed by fear of not, doing everything so to the T that we're not, we're losing all momentum forward. That to me is an example. Using it topically, is there some risk that 10 years from now they'll figure out that it caused a more aggressive form of melanoma or something? Sure, anything's possible, but like that to me is not as egregious an overreach as injecting it subcutaneously with zero evidence.
Right. All right. We got this question a few times, so I don't want to be accused of not at least asking it. I don't know that I even want to address it, to be honest, or I'm going to make a very simple, I'll make a very simple statement. How about the liability on the trainers who are training other medical professionals to inject a non-approved product? Seems insane and like cause for revocation. There are various ways that this was asked a few times. You have to ask them. I gave you some of their arguments too, and I gave you, my response to some of their arguments for all of that. I don't know what their liability. You really have to ask them. And a couple of you said I've been trained, and what should I do? You've got to you've got to make that call. We had a few people comment. I saw it especially on some of the posts. I bought $6,500 worth of this product, and now it's sitting in my drawer for all that. I mean, use it topically. I mean, I don't know what to do. How would you respond to any of that? I don't like bashing other people for that.
I
I would say
don't.
you've got to go back to them and say that, and they'll give you they'll give you some idea of what they're thinking.
Yeah, look, if you have the product sitting in a drawer, yeah, like you said, use it topic. I have no problem using it topically. All right. The risk you are undertaking there is minimal. So I'm fine with that. That's a for another conversation, but I have no problem with that. Don't make it go to waste. All right. When it comes to these injectors who have been training on it, look, a lot of them have been getting a lot of shit for they've been bullied. Some of them have been, drugged through the coals over that. And that is not Dr. Mockmakers. That is not my intention is to shame anyone. We're just trying to right the ship here. That's all. All right. Whether or not they are legally exposed, look, that's not your concern. That's not my concern. That's between them and their lawyers. All right. So, look, I think, and as far as regarding them, some of them I have a lot of respect for. All right. These are great educators in the field. And what I liken it to is like, look, I'm not always right. Lewis, you're not always right. Sometimes we make bad decisions, and I would hope that colleagues of mine would step in, and maybe when I'm not thinking clearly on a topic, they would help me out and say, "Look, you're not thinking clearly here. Let's redirect you." That's all I'm trying to do. So I'm not looking to attack or shame anyone. I'm just looking to right the ship going forward to get our compass, our North Star more aligned with science going forward. This is not about shaming or suing people or any of that. It's just about trying to get back to real science, the scientific method. No shaming, no shame.
Right. And I just say go back to them and ask them the question. Here's a really good one for this. And this goes into a wider problem there too. Are medical directors held liable in these situations? How are injectors performing procedures without their medical director's knowledge? Wouldn't the director be responsible for oversight? Holy cow.
Yep.
And I will tell you this. We speak to a lot of nurses that are either coming into the space or are in med spas and don't know that they need a medical director. You've got to know all the ins and outs, right? I mean, a medical director is fully liable for what goes in this, right, Christian?
Oh yeah, I mean, like, look, I have no sympathy for the medical. Some sympathy of like if you have rogue injectors under your license doing things that haven't been made aware to you, then yeah, sucks to be you because you are certainly medically liable. They're coming after your deep pockets, your ostensibly deep pockets as the medical director who's making, who owns the business. They're coming after you. You are now liable. So I would say if you are a medical director, if you do have injectors, doctors, nurses, PAs injecting under you, you need to have a meeting tomorrow. Like, hey, guys, just so we're all on the same page, if we're bringing on new modalities, it gets run through me because this is my license at stake. Simple.
Right. Is there any official statement from any of the medical boards regarding PDGF? Yes, I'll send you a link to our AAFE legal webinar, and you can see them because they're all posted there. So if you want to email me about that. Last question, just because it's past my bedtime. I'm old, and the Christian can go all night here. But curious about everyone's stance on biologics from C-section babies, Wharton's jelly, umbilical cords, etc. Any ideas on that, Christian?
I don't. Here's where I don't want to get too much on my pulpit and be like, oh, I don't want to speak about things about which I know nothing, and I don't know anything about Wharton's jelly or biologic or amniotics, etc. All I would say, we apply the same ideas that we presented here tonight. Follow the scientific method. If there is not evidence, if there is not research, be very hesitant to proceed, and certainly run it by your malpractice insurer, the underwriters, your attorney. If you're bringing on new things, make sure that they are both vetted by science, that they are approved by the FDA for some indication, and certainly run it by your own malpractice coverage and your attorneys. You have to do your due diligence, or else you are putting yourself at risk.
Well said. I'm going to end off with Rebecca's remark for that because I think it really says the whole thing. This was super inspiring. First of all, on behalf of Dr. Subio and myself, thank you. I am now more determined to learn, learn, learn. That is really what it's all about. I mean, that's really what it's all about. So I'm sorry if we didn't get to your questions, but Christian, it has been an absolute pleasure. I'm sure we'll be working on lots of other things together. And a lot of people were very happy with this. I mean, they just like it's just the openness, and we're all in this together. We're all here to really help each other for all of that. So I'll let you have the final comments there, Christian.
No, hey, look, thank you all for everyone who tuned in. Thanks for being on the right side of this. You guys tuned in because you want to do the right thing for your patients, and that is why I'm here. That's why Dr. Mockmunker's here. That's why we're here to do the right thing for our patients, to follow the science. So thank you guys for being part of this industry who cares about the science and doing the right thing in the right way. That's it.
All right, Christian, we'll talk to you soon. Take care, everybody. Continued success. We'll talk to you all again real soon. Have a great night.
Thank you.
Thank you.